So Dr. Pearlman is the director of the men's health program. She's an assistant professor in the Department of Urology. She has several research focus specifically in the hormone replacement. We have had several patients in common that have truly benefited from hormone replacement therapy, patients with brain tumors, post-sarcoma treatment. And then we conducted a sexual dysfunction study in AYA patients, which was it was an eye-opening study for us to understand how important this aspect is in this patient population. And she's also the integral part of an LGBTQ clinic that runs here at UIHC. So thank you for coming, Dr. Pearlman. And her topic today is treatment options for sexual dysfunction in AYA males. So go ahead.
Awesome. Thank you so much for the introduction. Folks, it is Friday afternoon and we're talking about sex today. Now, Dr. Garge made the comment earlier today that his job was pretty easy, but I can honestly say, I think my job might be the easiest out of anyone on this call in many respects, although not always. And you can see here in my credenza, it's not quite one's grandmother's credenza, but I have all sorts of toys and tools that we'll talk about in greater detail. As Dr. Manga mentioned, my name is Amy Pearlman. I'm a urologist. I specialize in men's health, sexual health, and transgender care, and I direct our University of Iowa men's health program. I do have a few disclosures. I am a consultant for and receive grant funding from Boston Scientific and Endo Pharmaceuticals. And for all the research and time and effort and money that companies like these two have put into research and development, that's why I can honestly tell a lot of patients and a lot of providers that there are very few men in whom I can't restore function, because I truly do have a lot of tools in my toolbox. For the next 40 minutes or so, we're going to go through a few objectives. We'll describe basic penile anatomy and mechanisms by which cancer treatments can impact sexual function in men. We'll talk about and outline our current knowledge of sexual dysfunction in AYA patients, discuss options for penile rehabilitation, list pharmacologic options and surgical options for the treatment of sexual dysfunction. Now, if there's one thing that you get out of the next 40 minutes, it is this following message. Your patient or a patient doesn't need to feel sick or feel like they need to be fixed to deserve to have an appointment with someone like me or with one of my colleagues. This is a message I've started telling some of my patients who, let's say after a 30 or 40 minute discussion in the room, they apologize at the end of that discussion and they say, "I'm so sorry for wasting your time today." And I tell that person this exact same message. And I say, if you have a question about your body, you deserve to be here. And so when it comes to this whole healthcare system, there's a lot of us in this healthcare system. I never want any of you to feel bad about making the referral. It is what I've chosen for myself in my career, is I'm happy to see any of these patients, even though I'm a surgeon, if only to talk and to educate. So when it comes to cancer and anatomy, and we won't get into the discussion of who created us today over the next 40 minutes, but poor planning. And if we look at a sagittal view right here, we have the pelvis, that organ that sits deep in the pelvis, and the prostate plays two very important roles in the body. It helps nourish sperm, and it also can be an organ for sexual pleasure, but it's an organ that can develop an infection, prostate cancer, and become enlarged when someone gets older. And if you just look at all the nerves that are in the pelvis here, then of course, any cancer treatment in the pelvis, whether it's radiation, chemotherapy, a mass, surgery, is going in some way, shape, or form to affect sexual function. And the same thing is true for our female patients. When we think about a prostatectomy, and even though our AYA patients are not going to be coming in for this surgery, I think this is a good depiction of what surgery actually does to the nerves, no matter how careful we are. And even if we use the most advanced technology like a robotic platform, we're still going to put those nerves on stretch and cause a neuropraxia. So it is very common, even if we're sparing the nerves, that those nerves for 6 months, 12 months, even up to 2 years, it can take that long for those nerves to recover. So when it comes to sexual dysfunction or erectile dysfunction, it is possible that over time, as those nerves recover, that might improve, and patients may not require such invasive therapy to restore their function. But it's not as simple as injury to the nerves. There's also injury to the arteries. And when we think about what creates an erection and maintains the erection, it's all about nerve function, the release of nitric oxide from those nerve terminals, but also good blood flow into that genital tissue. But surgery and all these different therapies can cause arterial insufficiency. And then with nerve injury, not only is it injury to the nerve, but you also have apoptosis and you get fibrosis. You actually get structural changes in the penis that causes scar tissue to develop. And then when it's not possible anymore for as much blood flow to come into that tissue, then that what used to be that great blood flow that could then block off and clog off the venous drainage from that organ, no longer can it do that. So then you can oftentimes have venous leak from that genital tissue. Now, when it comes to radiation as well, whenever it involves the pelvis, again, it's not one simple mechanism here. Radiation will cause neuronal damage and vascular damage and muscular damage that actually changes the structure of that tissue. And same thing with androgen deprivation therapy. And I like to even expand this diagram here. And we talk about ADT when it comes to something like prostate cancer. But if you just think about any therapy, chemotherapy, immunotherapy that can have an effect on testosterone and lower that level, then oftentimes you're going to see this whole downstream effect, changes in ejaculation, in orgasm, libido, decreased sexual activity, and actual changes to the genital tissue. Now, Dr. Monga had alluded to actually a different study, but this is actually another study that we worked on. And this was in malignant melanoma patients, stage 3 and stage 4. And we looked at testosterone deficiency in men receiving immunotherapy for melanoma. And what we found in this, albeit small, study of patients, it was a retrospective chart review for those who were treated with immunotherapy. We found that in 34 of 49 patients at some point during their therapy had low levels of testosterone, for which only 3 actually received treatment. And many of these patients were symptomatic. So a lot of patients will come in and they may not have or report decreased erectile function or libido, but fatigue is a very common symptom of low testosterone. And 43 out of the 49 of these patients reported somewhere during these course that they had fatigue. And 4 of these patients developed hypophysitis, which then led to pituitary issues. And when it comes to signaling and testosterone, all the signaling starts up here in the pituitary gland. So the reason why I bring up this study and why we talk about testosterone is because testosterone, hormones in general, if we think more broadly, are so critical to sexual function. So even though this study in particular didn't look at things like erectile dysfunction, if a lot of these patients have low testosterone levels, then we need to assume or make the assumption that a lot of these guys are probably also suffering from sexual dysfunction. So in terms of what we know about sexual dysfunction in pediatric cancer survivors, we know that especially for those who receive radiation and chemo, they're going to have higher rates of gonadal dysfunction and infertility. And those topics were delved into in further detail in earlier talks today. When it comes to the prevalence of erectile dysfunction among male pediatric cancer survivors, there's actually not that much information about it. And they actually have varying results. But if we just think back to the mechanism by which any cancer treatment can affect nerves and vessels and hormones, then most of these patients, we can assume are going to have some sort of sexual dysfunction. For studies that have been published, there was one here where males who survived childhood cancer were 2.6 times increased risk for ED than the average population. And we don't want to forget about women here. So even though my talk today is going to be focused on male sexual dysfunction, the other hat that I wear that Dr. Monga had mentioned is I do genital surgery for patients who identify as being transgender. So sex assigned at birth male who identify as female. And when I do that surgery, something what we call a vaginoplasty, I'm taking apart the external genital tissue to create new tissue, what looks like what we would call as female genital tissue. And the big lesson I've learned in learning and performing that operation is, wow, men and women, male and female genital parts are actually very similar. It's just our parts as women a lot of them are hidden, but the parts are actually very similar. So a lot of what we talk about nerve function and blood vessel function is going to pertain to women, and female pediatric cancer survivors have higher odds of reporting sexual dysfunction after treatment as well. So this was a study that Dr. Monga mentioned because there's a lack of research out here in terms of AYA patients and sexual dysfunction. We tried to at least, tackle a little bit of this with a multi-institutional study collaborating with the University of Miami. And then Lindsay Clifford was instrumental in helping us enroll some additional patients from the University of Iowa. We enrolled patients exactly in this AYA population from 18 to 39, and we included those who had recently diagnosed with cancer, were actively receiving treatment, or had plans or had completed treatment within the last 6 months. And we gave them a variety of validated surveys. So overall, our study showed that 58% of these patients had erectile dysfunction. 72% of men younger than 30 years old had erectile dysfunction. And the highest rates of erectile dysfunction were seen in those undergoing chemotherapy. So as Dr. Choi had alluded to during his talk earlier today, maybe the simplest thing that we can do, and maybe the only thing we really need to do, is to ask our patients if they have sexual dysfunction. And even if the research showed us, even if the research told us that these patients were at no higher risk of sexual dysfunction, folks, I don't think any of us would believe that research. It just doesn't make sense from an anatomical reason from what we know about where all these body parts and organs are located. Okay. So let's get into this, what this conversation looks like, because perhaps the conversation is the toughest part about this whole talk. I was at the VA. I go to the VA on occasion, and at the VA, we sort of see any patients that show up into the clinic, and those could be outside of our specialty. So I acknowledge that when I'm seeing patients over at the Iowa River Landing Clinic, there's some sort of specialization there of people who are funneled into my clinic, but at the VA, I could see anything. And it really dawned on me in that moment when I was seeing a gentleman coming in for elevated PSA and we were going through the whole discussion of prostate cancer. I was thinking in my head, okay, Amy, do I bring up the sexual health concerns? Because we've already been speaking for like 30 minutes, 45 minutes about PSA and prostate cancer. Do I have the bandwidth, the time? Does the patient have the bandwidth and the time to then open up this whole other discussion about sexual health? And so I acknowledge that for pretty much everyone on this call, it is too much to have all of these conversations. And that can be really tough to do. One, it can be out of your expertise, but two, you just may not have the resources to have that nuanced conversation. But our patients want to talk about sexual health, right? And in this one study, most pediatric oncology clinicians identify that they do play a role. You all identify that you do play a role in the discussion of sexual health, but oftentimes people feel like they lack the proper education and support. When I think back to my training as a urology resident, I spent 5 years learning how to do surgery. Now, sure, I was in clinic for part of those 5 years, but as a surgical trainee, nobody as a resident ever looked forward to being in clinic. It was almost like punishment if you had to see patients in clinic. So it really wasn't until my fellowship year, I did fellowship at Wake Forest, where I learned how to truly have conversations with patients, going back to the basics of their bodies and talking them through all these different options. But it was during that 6th year of training that I learned how to have these conversations. And if I didn't see anyone have these comprehensive discussions with patients, the conversations that I have today would not be as comprehensive as they are, simply because I wouldn't have seen someone do it. Now, when it comes to adolescent and young adult males, it's much more than erectile dysfunction. Like, the ED part is probably the easiest part about my job, because, if someone fails all the different medication regimens, I can put a penile implant in most patients as long as they're, safe enough to have a surgical operation, and I can easily fix the erectile dysfunction. So if only it were that simple. But when we think about these patients, especially young patients, we also have to consider a whole host of other things that fall under this erectile dysfunction umbrella. And more broadly, we should talk about sexual dysfunction. So first is how one experiences pleasure. Is it with self-stimulation, vaginal penetration, anal penetration? Are they the giver? Are they the receiver? think about, prostate cancer, removing the prostate, or radiation to the pelvis, if that person experiences pleasure with, being the receiver with anal penetration, there are real implications for guys when we radiate that area. Now, the importance of producing an ejaculate, even separate from the infertility implications for a lot of men, regardless of age, they could be 20 or 90 years old, forming an ejaculate is oftentimes a part of that sexual experience. Loss of penile length and girth. A lot of men are not told that if you don't use it, you lose it. That no truer words could have ever been spoken. And we must discuss the role of penile rehabilitation in preserving length and girth. Concomitant urinary leakage, leaking with climax, communication with current and future partners. The mental health component has been discussed multiple times today, and I think is one of the hardest components to treat when it comes to sexual dysfunction is changing this mindset of patient and provider into maybe just 5 or 10 minutes a day of going back to what it means to be husband and wife or husband and husband. And that conversation is really difficult to do because those scripts change. Whereas when someone was, let's say, 25 years old, a couple, both are 25, and then the gentleman has testicular cancer, has the testicle removed, maybe needs an RPL&D, makes it more difficult to then get, erections. Then what used to be this sexual script of, hey, babe, do you want a glass of wine tonight? And both people kind of know where that's going, becomes, should I get my vacuum pump? And how are we going to do the injection? I have to wait for that to thaw out. And it makes it a lot more complicated. And it's possible, but oftentimes two people don't come together to say, how is this actually changing our sexual script? And what does that look like now? Talking about pre-treatment erectile function, Dr. Choi mentioned this, the rehabilitation, the time for patients to get, any of these sex toys and tools and to understand the role of lubrication and rehab and vacuum pumps and injections is before we radiate and before we start people on chemo and before we cut through those pelvic floor muscles. And, if I had my choice, I would see every single patient, before they have their prostate removed or radiation. And because the time to really have that conversation is beforehand. And then the implications on energy level. It doesn't matter if someone really wants to have sex, for example, that can be a very strenuous activity. And sometimes, people just may not have that energy to engage in that activity. Interest, libido is a very complicated thing, sometimes related to hormones, sometimes related to, it's just so difficult now to reach climax or to have the conversation that I'm just not interested. And then current chemotherapy. So implications on, having chemotherapy in one system and appropriate protection methods in those scenarios. So that's a lot of information that I just discussed, but we're going to get into the really fun part about today's conversation, which is all the different tools that I have in my toolbox to help people. And in order to understand these tools, we have to go back to basic penile anatomy and understand that the penis is truly a sponge. And I'll talk a little bit about what this 30-second script looks like and when we should have these conversations. But the short answer is as early as possible. And we know that impacts changes in therapies and outcomes in the future. Because if we think about the penis as a sponge, imagine a sponge and imagine me putting the sponge under a faucet and wringing it out. And then I leave it there and I say, Mr. Sponge, I'm going to see you in a year. And then I take that sponge and just imagine what that would look like. I don't have an example to show everyone, but it's an old crusty sponge. Okay. And if I take that sponge and I put it under the faucet after a year of not being under that water, it's not going to expand like it did a year ago. Now let's take another scenario. I take a different sponge and I put it under the faucet once a day, just for like 10 seconds once a day. That tissue, that spongy tissue is going to be a lot healthier and expand a lot more than that first sponge that I discussed. That is the penis, that is rehab, that is the importance of early intervention when it comes to rehab. This is a cross-sectional view of basic penile anatomy. This is literally the spongy tissue. When I do bottom surgery on patients, I am literally scraping off this spongy tissue from the underlying tunica albuginea. It is that sort of like tenuous and soft, and but it's like this incredible thing that can expand when you get blood, but it is literally spongy tissue. So when it comes to demos and recommendations that I go through when it comes to all these different therapies, I keep these in my office. So I have a set at home because I do a lot of webinars from home and I like to show these examples, but I also have all of these different products in my office. And there was something that happened about 2 years ago. I was at a conference in Chicago and the waiter came out with this tray and it was at a fancy seafood restaurant. And on the tray, it had the lobster and it had the crab cakes and the salmon and the steak. And he went through with like the most passion I've ever seen a waiter go through a menu before. But I had an epiphany in that moment of him presenting that tray. And his message was, to simplify it, was, I don't want any surprises. If you spend $30 or $40 and you order the steak, I want you to know what you're getting before you get it. So when you get the steak, and if you see that it's not as big as you thought it was going to be, that's on you because you saw that steak before you even ordered it. And then we're given the bill at the end, of that restaurant visit. And that's how I think about all these different products. I don't want my patients to be surprised. Oftentimes in their journey of sexual health and cancer care, whatever their reason for sexual dysfunction, they've had enough surprises, and I want to take the surprises out of it. So I will show them what the needle looks like. And it's not to scare anyone, but if they're going to spend $150 on a vial for penile injections, I want them to know what that looks like ahead of time so they're not wasting their money. So people may like surprises when it comes to someone's 40th birthday. They don't like surprises when it comes to their genital parts. Vacuum erection devices are devices I used to counsel people against, and now they are one of the most useful tools that I recommend to patients. Vacuum devices are external devices that you fit over the penis like this. You can do one that's battery powered. There are other ones that are manual, and it physically is sucking blood into the penis. This, whenever I bring up a vacuum device, the analogy I give is that sponge. So while we're trying to figure out if Cialis or Viagra is going to work, or if injections are going to work, or someone is actively going through chemotherapy and they want to just prevent the penis from changing at a structural level, that's where vacuum pumps are incredibly helpful. Now, do I think vacuum pumps are a great therapy before sexual activity? Not really. They're a bit cumbersome. They can make the penis, change color, feel a little chilly. They don't give a rock hard erection like some of the other therapies, but they are incredible tools when it comes to rehabilitation of the penis and stretching out that tissue. Now, if I just mentioned without showing any demo products and recommended that patients get a vacuum pump, a lot of them wouldn't get it because it's no longer covered by insurance. It used to be covered by Medicare, no longer is covered by Medicare. So you really don't see these often in medical offices anymore. And there's not a prescription that I can send for patients. So what's been super helpful, critical, game-changing in my clinic is giving people a place to start and saying, I don't care which one you get, but if in a year, if you don't rehab your penis, if you would be upset or frustrated or angry or sad if your penis got smaller, then you must do penile rehabilitation. And it puts some accountability on the patient to then do these exercises on a regular basis. But I tell them, just find one that's within your price point. And I give them a list of different recommendations at different price points. And there's oftentimes one for people who, let's say, are limited on financial resources, where they can find one that will still work for them that might be $30 or $40. But I'm giving them a place to start. Rather than saying, oh, go on Amazon, go online, go to Romantics. It's like walking into Walmart and just, walking in saying, I just want to make a decent protein shake in the morning. I'm going to walk into Walmart and get a protein, a blender. You walk down that aisle and there are 20 or 30 options. You become overwhelmed, different price points. You don't know if you need the fanciest one, the cheapest one in the middle. So you walk out empty-handed. This is a way to prevent patients from walking out empty-handed, is providing them, New Care Pharmacy carries these in stock in person just down the road. And I give them places where they can order online. And then I give them a starting regimen. So even though there's not a lot of research out there when it comes to what the ideal protocol is when it comes to rehabilitation, the goal is 10 minutes a day. This is a protocol that Mary Hausler, a pelvic physical therapist, came up with. She did the research and looked at what was available And we came up with this regimen. Again, it's telling our patients, we recommend this product. Here's a starting regimen. See what works for you. If we don't provide this detailed guidance, patients, may just not know if 2 minutes is enough, if 30 minutes enough, and really 10 minutes is probably good enough when it comes to rehab. And then traction therapy. So if this looks like a medieval torture device, it's pretty much what it is, although it is a very good product. The RestoreX device was developed out of Mayo. It is a penile traction device. It is a spring-loaded device. It's an incredible piece of equipment. It is for people who lose length and want to restore length. So you would put the penis in like this. You would actually clamp the tip of the penis underneath this lever right here, and it allows you to hold the penis straight out. And for guys who also may develop penile curvature, it allows you to then stretch the penis in the opposite direction when in the flaccid state. So this device is now increasingly being used with a lot of research for post-prostatectomy patients, because we talk about erectile dysfunction most of the time as a common complication related to prostate cancer treatment. What we don't talk about enough is as soon as that patient wakes up and he looks down, his penis is smaller. And we don't oftentimes bring that up when it comes to informed consent, whether related to radiation or surgery, but it is a real thing. And it's probably related to changes in the nerves and the vessels that we discussed before. And just even outside of wanting to put a penis in a vagina, changes in penile length have real implications on a person's sense of masculinity and on their ability to urinate. So this RestoreX device has shown that in terms of changes in penile length compared to controls, it can increase the size of the penis by 1.6 centimeters. So we're not talking inches here, but it's something. It's something that when our patients come back and they see progress oftentimes leads to hope. Now, sex toys and tools, one of the most interesting parts about my conversation these days, and actually a new discussion that I've added into my talk track in the last 3 to 6 months, is I'm talking about vibrators, which is definitely not anything I was taught about in surgical residency or fellowship, and is something that I pretty much talk about with all of my patients these days, cancer patients, non-cancer patients, you name it, we talk about vibrators. So vibrators, I like to use the analogy that if I'm in the kitchen and maybe you made yourself lunch today, or think about dinner last night, if you are making yourself zucchini or squash and you want to make like spiraled spaghetti, you don't do that with your hands. You use equipment. You use tools in the kitchen to make that easier to make zucchini spaghetti. It's the same thing when it comes to intimacy and sex. Vibrators can make it easier. Chemo and radiation and surgery changes nerves. They can change sensation. You add on diabetes and heart disease and all these other things. Sometimes it becomes really difficult for patients to feel their genital parts, let alone have function and orgasm. So vibrators increase stimulation to these parts and can make it easier for folks. It's also something that can be very useful for people as they are actively going through, let's say, hormone therapy or chemotherapy, and let's say are not going to be having partnered activity, or let's say someone who, is so tired that it's really difficult for them to engage in penetrative intercourse. And so using something like this can just make it easier and less strenuous to achieve orgasm. Vibrators are incredible for this. People can get it. I'll pull up websites online. New Cara Pharmacy, that compounding pharmacy just about 7 minutes away from our University of Iowa, has started offering and selling vibrators as well, so that we can medicalize these. I actually stopped referring to vibrators as sex toys, and I refer to them as sex tools. And as far as I'm aware, I have yet to offend any of my patients, even the 70-year-old Iowa farmers in my office. A lot of them, their partners, they have these sex toys and tools, and I recommend that actually our male patients get them as well. When it comes to medication considerations, we have a lot of different ones here. They act on different mechanisms. Mostly the pills are going to work on the nitric oxide pathway. That pathway gets disrupted when it comes to radiation and surgery. When it comes to injection therapy, that actually works on the ATP cyclic AMP pathway. So they work via 2 different pathways, which is why even in our guys who have, let's say, prostate cancer, major pelvic, surgery, colorectal cancer, perhaps in our AYA population, the injection medications may be more beneficial in those patients because it's separate from that nitric oxide pathway. We have 4 FDA-approved medications to treat erectile dysfunction. I oftentimes will use Cialis. I wish Cialis were in the water. That would be my dream. I'm not a pill pusher by any means, but I do feel strongly about testosterone and Cialis in appropriate patients. Cialis just allows nitric oxide to stick around longer in the penile tissue, makes it easier to get good erections, and can be a great part of a penile rehabilitation program, along with something like a vacuum pump. When using these medications used to be cost prohibitive. If you don't use GoodRx for any medications, it is like the best thing that ever happened to me for my patients is finding medications where they can get it for a really cost-effective price. GoodRx for 90 pills of 5 milligrams of Cialis, $15.64 at Hy-Vee. I tell my surgical trainees, you can do some big operation on a patient and save someone's life. Nobody is as grateful as when you get them 90 pills of low-dose Cialis for $15.64. When it comes to hormones, incredibly important. I highlighted from our national guidelines on testosterone deficiency, the patients in whom we should consider checking testosterone, even if they're not coming to us specifically for erectile dysfunction. And when you look at these highlighted terms here, it's pretty much all the patients that all of us are treating: exposure to chemo, exposure to testicular radiation, chronic narcotic use, pituitary dysfunction, and chronic corticosteroids. So if we make the assumption that, a lot of these patients are having sexual dysfunction, we can also make the assumption that a lot of these patients have hormonal issues, both in men and women. And the nice thing is we can easily check with a blood test. We don't actually have to assume anything. When it comes to the symptoms and signs associated with low testosterone, if you read these here, I think a lot of us on this call would say, yep. I check all of those things. And when you think about our AYA patients who undergo therapy, you're like, well, of course they have reduced energy. And of course they have reduced lean muscle mass and fatigue and depressive symptoms. We have them on chemotherapy. But a message that I like to give to people like Dr. Manga and people like Carlos Chan, who, both of them treat really difficult to treat cancers, is, again, I have a lot of these tools in my toolbox. And for the patients who, let's say, are on these therapies and they have low testosterone, my question is, gosh, I wonder if I can help. I wonder if we treat their low testosterone, it may not be the same game-changing improvement in symptoms that my 35-year-old guy has who doesn't have any major medical problems. Like for that 35-year-old guy who's otherwise healthy, it can be a game changer to put him on testosterone. But with Dr. Manga's patients, with Dr. Chan's patients, I'm thinking maybe we can improve their energy just a little bit. And folks, those small gains, those small wins can be really big wins for these patients. Other therapies, when the medications don't work, a lot of different things. We can put medication in the urethra. We can inject the penis, and I can put penile implants in. So I like to ask the question of, how long do you think penile implants have been around for? And a lot of people respond with, oh, they must be the newest and the greatest technology. I've never heard of that before. I've heard of breast implants, never heard of penile implants. Folks, penile implants have been around for almost 50 years, 50. So because I can literally replace the hydraulics of the penis, that spongy tissue, with cylinders, this is why I can confidently tell most people that I can restore their sexual function. It has nothing to do with me, but other people have put in the time, and I'm just lucky enough that I get to use devices like this. Now, when it comes to this 30-second script, because we have a lot of options here, the message for each of you on this call who have a difficult enough job anyway, treating and managing cancer patients, is the following. This 30-second script makes it super easy to do. It's a short message about sexual health. It normalizes the discussion of sexual health, and it's an invitation to the patient to discuss sexual health now or later. It was really refined by Erin Sullivan with her All of Me initiative and Veronica Calder. And them teaching me about this 30-second script has revolutionized the way that I interact with patients and providers. These are the 6 key points in the 30-second script. It's acknowledging, and you can come up with your own 30-second script for the patients you see, but in general, this is what it looks like. Sexual health side effects are common and expected. Sexual health is important to quality of life for many people. Sexual side effects are health concerns. Support and resources are available. You might care more later. I know you were recently diagnosed with cancer and it might be overwhelming right now, but life is long and you may care later, and sooner may be better for treatment. And then in your own practice, you can decide for yourself, is this a conversation about sexual health that you want to have, or do you want to refer them to someone else? And folks, either are perfectly acceptable and okay. And then discussing these additional conversation points when it comes to nutrition and exercise, nicotine cessation, alcohol, fatigue, hot flashes, bone and heart and mental health. That's why I feel grateful to have other people like Dr. Carr on the team and our nutritional support, because we don't have to be everything for everybody. I do get into nutrition, anti-inflammatory diets, talk about the role of, red meat and processed meats, but I don't go into a whole spiel about it. I introduce it and I provide some resources for patients. So with the last remaining minutes here, let's talk about some take-home messages. When it comes to sexual health in cancer patients, there is help and therefore there is hope. This multidisciplinary approach leads to optimal outcomes. Sexual health should be brought up early and often. Whenever we bring up quality of life concerns, bowel function, bladder function, fatigue, we must also bring up sexual function. This 30-second script can be a useful communication tool, and have an exit strategy, whether it's educational material, referral network. For me, my educational strategy are YouTube videos. I create YouTube videos and I tell my patients, we're going to go over the high level stuff today. I'm going to introduce, we're barely hitting the iceberg when we come to talking about vacuum pumps and something like Cialis. When you go home, I'm going to give you some homework. I want you to watch some additional videos here to really get at what all the options are. But realizing for myself, I don't have to tell them everything they ever need to know about sexual health and treatment options during that 15, 30, or 45-minute visit. Everyone has their own pain. What a beautiful thing. The problems that I see patients for in my clinic, if you were to give my clinic schedule to any one of my 16 faculty member colleagues in the Department of Urology, all 16 of them would quit in a second. They just don't want to talk about the things that I love talking about. But it's the same scenario with my colleagues. If you were to say, Amy, you're going to see kidney stone patients all day, I would probably quit too. But the beauty is we actually have, all of us have our own pain. All of us have all the different things that we want to talk about, so we can actually fill all those gaps. We can take a breath of relief. We don't have to be everything for everybody. We have so many people here at the institution, at the University of Iowa, in the state, in the country, who actually have the expertise to help our patients. This is our testicular pain team. This is my team of people all across the university and outside the university who helps me take care of a single problem. And when I send someone to each one of these people, I know that I'm sending them to a specific person for a specific reason. But the only way to create this team of faces that we actually recognize is to sit down with each person to say, what do you like to do? What do you like to treat? Where's your expertise? If you see this referral from me, will you be happy or sad? And then you want to just find all those people that will be happy when they see the referrals come from you. And then understanding that we, as, let's say, physicians, we don't have to do it all of ourselves. I work with incredible medical assistants in my clinic, Christine, and Tim, and they have incredible passion for talking about sexual health and men's health, that our medical assistants, sometimes they'll have the whole 10, 15-minute discussion, and then they'll report the patient to me or talk to me about the patient. I go in and I wrap up the session. So thinking about all the members on our team, not just physicians, who can have these nuanced conversations with patients. And then in terms of what may be most relevant for people on this call, within our own walls of the University of Iowa, we have our men's health clinic. We have the menopause and sexual health clinic that focuses on female sexual dysfunction. And we have our pelvic floor physical therapist. So if you don't have the expertise or the time or the bandwidth to get into the nuances of sexual health and management and evaluation, as long as you bring up the topic, all you need to say is, sexual health important to you? Would you like to see someone? If the patient says yes, place a referral, and literally anyone on this PowerPoint document right here would be thrilled to see that patient in any of our clinics. The University of Iowa is a very special place. I'm from the East Coast. I don't know if you can tell from my personality or my loud voice, but what I will say after being here at the University of Iowa for the last 4 years is that this place is a gem in the Midwest in the world. And I just think about a curious mind, and we think about cancer care. Could it be that the University of Iowa and the state of Iowa is this incredible place for collaboration, comprehensive care, convenient care, cost-effective care, utilizing resources like Dr. Carr's with providing exercise tools for patients at no cost? Maybe sprinkle a little Cialis in here to get this sort of like perfect care algorithm for patients. Maybe it needs to live in a center outside of our huge hospital center. A girl can dream, right, in terms of a separate clinic for these patients, maybe AYA patients. And the next thing I think, and I'm going to wrap up this talk, is maybe the next step before we have our own center is a roadmap. This is a roadmap that me and an MD PhD student, Wade Gutierrez, came up with when it comes to men's healthcare. It's something we're presenting to men in fraternities at the University of Iowa. It's not enough to tell young men, see a healthcare provider if you have a concern. This is the clinic. This is the address, the phone number, the access, who accepts insurance, how long it takes to get in for a clinic visit. And maybe the next step is we come up with a roadmap for our cancer patients that actually knocks down all the barriers of calling some generic number and says, if you have sexual dysfunction, call this number. Dr. Pearlman would be thrilled to see you. So that's all I have. And I guess we're going to get some questions for all of our speakers. Thank you.